Bene, con piacere, con immenso piacere, vi presento il professor Dominik Straumann dell'Università di Zurigo.
Okay, thank you very much to the organizers, especially Professor Neri, for the invitation. I was very glad to come, and it's a wonderful atrium or aula, and I would really like to tell you things about concussion in sports and what it relates to neurovestibular aspects. And I'll give you a little outline of the topics I'm going to cover. First, I want to give a little introduction and also what the definition is of concussion. Then why or how I became interested in concussion. That's not so long ago, 9 years. Before that, I had no idea how concussion would be interesting for neurootologists. Then I would like to go into the problem of vertigo or dizziness after concussion, namely that it can have multiple causes, and we are not used to look for multiple causes. We always like to have one cause, but in concussion, this is just the opposite. Then about peripheral vestibular damage after a head trauma, we have to decide, was it a commotio labyrinthi or was it a contusio labyrinthi, or was it both? How can we do that? And then, very important, I would like to discuss the sport concussion assessment tool, the SCUT, and especially the neurovestibular aspects in it, because I'm sure some of you will probably also be involved in sports, in soccer, maybe as a parent of soccer-playing children or even as a trainer, and then you have, I think, to know what the guidelines are and what mistakes you can make. And I will also touch on accelerated return to play for athletes that have a pure peripheral vestibular vertigo, because these people, as you know, can profit from a very strict and fast vestibular rehabilitation. And finally, I will touch on the vestibular testing battery, and that it is important to have, if possible, baseline testing, because the inter-individual differences are so large. Now, let's start very basic. What is concussion? Concussion is a traumatic brain injury which is induced by biomechanical forces. And I want to give you an example of a relatively recent concussion in soccer, which a Swiss player was involved with. And you might first think about it, what you think, what type of concussion, what would you do with a player? So let's take a look. So the player, Fabian Schär, he is a player with Newcastle, but this is a game of the Swiss national team against Georgia. And what you probably can appreciate is that shortly after the head hits the head of the other player, Mr. Schär loses all the tone of his body and just it's very floppy. And he loses consciousness for a few seconds. Actually, one of the players of Georgia took his tongue from the back a little bit forward because he was afraid that he would swallow his tongue because he was unconscious. And this really caused a lot of discussion, because when the player was interviewed by Blick, which is a very popular newspaper in Switzerland, he said, "I cannot remember anything. I was knocked out for a few seconds. My skull is still buzzing. I also have neck pain and a bump on the forehead, but it was worth it." And he actually, this was just before the end of the first half, the team physician of Switzerland gave him the permission to play for the second half after this concussion. Now, this is my only Italian slide. You can read it. So there was a lot of controversy whether this was actually allowed, whether the team physician of Switzerland actually made a mistake. And Headway, which is an organization in Britain, which is concerned with patients and also people in sports that get a concussion. Peter McCabe, he said, what is it going to take to make football take concussion seriously after this event? Put simply, the decision to allow Fabian Schär to return to the field of play after suffering a clear concussion was not only incredibly dangerous, but also a clear dereliction of duty. And finally, the player comments after the match are also deeply disturbing and again show a lack of awareness and understanding among players. And finally, he said, how many more players will have their careers and more importantly their lives and long-term health put at risk by the sport's inability to follow its own protocols. And I will come back to those protocols. So it seemed that even the team physician of a national team wasn't aware of the protocols that were written by his own organizations. Now let's step back. What causes concussion? So it's either a direct blow to the head, face, or neck, or it is a blow elsewhere on the body with an impulsive force transmitted to the head. Now, what are the signs and symptoms of concussion? Now, this is a very difficult question because there is a wide range of clinical signs. There's neither a biomarker nor there is a typical singular sign or symptom that tells you this is a concussion or this is not a concussion. And also, and this is an error many people still make, it does not necessarily involve loss of consciousness. This is not necessary to diagnose a concussion, the loss of consciousness. Now, fortunately, the natural history of concussion is usually typical. So there's a rapid onset of neurological impairments. You immediately see what's going on. You can make your decisions. But in some cases, the signs and symptoms can involve over a number of minutes, sometimes hours. So it doesn't have to be immediate. The time course is also usually good, typical. There is a spontaneous, sequential resolution of signs and symptoms. But again, in some cases, maybe 10 to 20%, the symptoms are prolonged. Now, what kind of deficits do we expect in concussion? Now, just generally speaking, we assume that there are neuropathological changes. We just don't know, but we assume that this is the case, and this is really a matter of basic research to find out whether deceleration for certain amount, let's say 70 Gs or 90 Gs, will actually cause damage within cells. This could be, you wouldn't see that on an MRI. But even if that's true, the acute clinical signs and symptoms largely reflect a functional disturbance and not a structural injury. And that's why you cannot see any abnormality on standard structural neuroimaging studies. And this is the beginning of the discussions with insurances. You know, they still think if you cannot see anything in the MRI or CT scan, there's nothing we have to pay. But in concussion, we do not expect abnormalities in the standard neuroimaging studies. Now, concussion is very strictly defined in terms of that it concerns the brain. So the clinical signs and symptoms of concussion should not be explained by, for instance, that the patient had taken drugs or alcohol or is under medication, because these symptoms can also be caused by alcohol, of course. By other comorbidities, you have to exclude those, psychological factors, other conditions. and then explicitly peripheral vestibular, cervical, and other injuries. And this is now the beginning of a problem. We are talking about concussion, but per definition, concussion concerns the brain. But as you know, all know, dizziness, vertigo can have central reasons, can come from the brain, but it can also be peripheral vestibular. And then to speak about concussion is not that correct. So you probably should speak, and that what I would propose about the concussion associated dizziness or vertigo. Then you don't already tell somebody else that is from the brain or from the labyrinth. Now, let me come to a case that actually started my interest in concussion. That was 10 years ago. This is German. This was, at that time, we still used faxes. It was the team physician of an ice hockey team close to Zurich, and he sent me an ice hockey player who also played in the national team. It was just about 3 months before they went to Vancouver to the Olympics, and he wrote that after he was hit in an ice hockey game, that he got on one side permanent diffuse disbalance, but also a position-dependent dizziness. And now he asked, what is the etiology? What can we do? Can he go to Vancouver? And he also sent me an MR, which was totally normal. Unfortunately, I haven't seen the patient immediately after he got the concussion, but it was already on day 18th after the head trauma. He complained of dizziness during exertion, training, but also during head movements. He also told me that it takes longer to focus things with the eyes. And when I investigated him, I saw an apogeotropic, mainly vertical positioning nystagmus when I put him into the right hallpike position. And I thought it could be a left anterior canalitiasis. So what I did the Jacovino liberation maneuver, which we typically do when we see this, which is extremely rare, apogeotropic vertical positioning nystagmus in a hallpike position. But this is what I did with the patient, this Jacovino maneuver, which takes care actually of both anterior semicircular canals. Now, the next day, so this was the second visit, he had unchanged complaints, still dizziness during head movements and difficulties in focusing. And when I again investigated him, I saw a geotropic horizontal positioning nystagmus in supine roll positions, more on the left side than on the right side. So I thought this is now a typical lateral canalitiasis, geotropic, and I did the Guffoni liberation maneuver with the head down. So I did this maneuver here, go to the side and then turn 45 degrees down after 20 seconds and stay there for about 1 minute and then put the patient up again. Now the third visit, which was again 3 days later, he was already back in training. He had dizziness only with rapid head movements, and when I investigated him, head impulse test, by the way, was normal. He just had a minimal geotropic positioning nystagmus after supine roll to the left. But I decided not to do any liberation maneuver and just recommended that he should go to full training and ignore residual vertigo and come back in 3 weeks. And when he came back, in 3 weeks, he was symptom-free. He was fully reinstated as a regular player, normal neurological findings, and I told him he should not come back. It's all fine. Many years later, he came back, but because he had another concussion. But from this concussion, he was symptom-free, and my conclusion was all his problems were mainly labyrinthine. It was not a a central problem, because he quickly recovered when I did repositioning maneuvers. So we would think that this is a commotio labyrinthi, which causes the concrements to being displaced from the otolith organs in some of the semicircular canals. Maybe in his case it was the anterior. We can discuss whether this is really true, but in one case it was also very clearly the lateral semicircular canal. Now, if you have a head and neck injury, you always have to be aware that it's both the head and the neck typically that are affected, and in the head you will find that the brain is affected, the labyrinth is affected, and other structures can also be affected. Now, if somebody has a concussion-associated dizziness, the question is, where do we now put the origin of the dizziness? Of course, we can exclude that it is a contusio cerebri because we can make the diagnosis with an MRI or a cerebral edema. We know that. But there are several other possibilities that could cause this dizziness. And as clinicians, we are used to use this word, numquam ponenda est plurilata sine necessitate, or in English, plurality must never be poisoned without necessity, which is Occam's razor. And so we always think, oh, he is dizzy, he got hit his head, so it must be a concussion, commotio cerebri. So that was William of Ockham. Occam's razor, all things being equal, the simplest solution tends to be the one. But in the case of a concussion, I would propose that there is another instrument that we should use, just very much the opposite, which is Occam's rake. We should think that when all things are being confusing, collect those that may significantly influence the solution. And that's what we should do when a patient gets a concussion. We should look for the many different reasons for the dizziness, and then decide which should be attacked or treated. And in a very good paper, actually, this was already stated in 2017 by the group of Barry C. Mungal. Patients with chronic dizziness following traumatic head injury typically have multiple diagnoses involving combined peripheral and central vestibular dysfunctions. And they conclude from this paper that in head injury, we recommend a comprehensive clinical and laboratory battery approach. So we should really use this Occam's rake and see at what level the vestibular signal processing is being disturbed. So if we look at the concussion-associated dizziness, we will see whether it's a commotio labyrinthi, a contusio labyrinthi, a commotio cerebri, but also neck problems, as was mentioned before, can induce dizziness. So we have brain lesions, and of course the brain lesions can be at several positions. The cerebrum, cerebellum, brainstem. This is very difficult sometimes to find out if we don't have any structural damage. So it's really the clinical investigation that can pinpoint where the problem in the brain comes from. Then we have the vestibular lesions, which can be, of course, in the semicircular canals or the otolith organs or both, and then the cervical lesion. Now, in traumatic brain injury, it is a tradition that we use the so-called Glasgow coma scale. So if somebody has an accident with a head trauma and he has to go to the hospital emergency unit, the first question is, was the Glasgow coma scale? And the Glasgow coma scale consists of 3 parts. It's always the best response, whether the patient can open his eyes, whether he can respond verbally, and what is his best motor response. And if he is perfect, he has 15 points, and if he has, in one of those less, then the points get less. And we define a minimal traumatic brain injury as a brain injury with GCS 15, and typically sport concussion will be in these terms minimal or only a little bit of the GCS affected, maybe maximally 13, but typically 15, 14. In the case of Fabian Scherif was of course more because he lost consciousness. Now, where do we put the peripheral vestibular damage in the same scheme? So we would think if we have a minimal problem, we would rather expect a commotio labyrinthi, and with stronger head decelerations, we would expect a contusio labyrinthi. And somewhere in between, we will have a spectrum with probably both. Another paper, which was a little bit earlier, made that very clear. It was called Brain or Strain. Symptoms alone do not distinguish physiological concussion from cervical or vestibular injury. These authors, they tried to distinguish from the history, from the science, whether the clinician could decide it's cervical, peripheral vestibular, or it's the brain. And this is not possible. So if you have a patient with dizziness, concussion, it's not possible in the beginning to decide it's peripheral, it's central, or it's both. There is a trend. Concussion patients have more headache maybe than the vestibular only patients. They usually have problems with sleep. They sleep longer, which is not typical for the vestibular injury, and they are maybe more fatigued. But again, all these were trends. These were not significant. Now, as a matter of definition, a contusio cerebri, as we already mentioned, can be diagnosed if you see structural brain lesions with a standard MRI. That's clear cut. Like here, many times you also see bleedings and areas that are just with a different intensity. Now, in the contusio labyrinthi, we don't have these possibilities to picture the lesion, but what we have is we have the vestibular tests. So the contusio labyrinthi you can identify with your vestibular tests, probably mainly with the apparative vestibular tests. Are there anamnestic clues that let you decide between brain and labyrinth? Imbalance doesn't help you. It can be brain, it can be labyrinth. If the dizziness is evoked by head or body movements, it's more likely to be labyrinthine than a pure brain concussion. If the dizziness is triggered, such as in positioning vertigo, you would rather think of a commotio labyrinthi, or if it's exacerbated, it's probably a one-sided deficit in a contusio labyrinthi. So what you have to do, and that's the procedure, you always have to exclude a central cause. Before you excluded it, you can never be sure whether the dizziness, vertigo, is peripheral or central. So again, you need a normal MRI. By this, you exclude the contusio cerebri, and you need to exclude the commotio cerebri. And there you need actually to know what happened. You need either to see the video or you have seen it by yourself to decide whether there is a commotio cerebri. It's very difficult if you see the patient, but you didn't know what happened. And again, the initial signs and symptoms may be very unspecific, and there are no neurocognitive or oculomotor deficits. Typically, if it's peripheral, but again, this is also not always 100%. What is also very atypical for a peripheral vestibular is persistent headache. Persistent headache points more into a central problem. Now, let me now go to the regulations that have been put up by several of those sports organizations like the FIFA, like the Olympic organizations and so forth. Because they really take a lot of effort to make it clear, and they always revise it. So this is already the 5th edition. That's why it's called SCAT 5. And whenever there are new insights, they immediately update their assessment tool. But still, as you will see, there are, in my opinion, some things you can improve as from neurovestibular aspects. So the SCAT consists of 2 parts. There is an immediate part, which is done on the field most of the time, at least in soccer. And there is a second part, which is done off-field or in the office of the physician. Now, the immediate or on-field assessment consists of red flags. If red flags are there, the player has to come out. Sometimes he has to go immediately to the hospital, but he can never continue to play. And these are 9 items. I will come back to those. 2 of those items are potentially of neurovestibular origin. And then there are observable signs that you can see either direct or on the video. They are 5 items, and 1 contains neurovestibular aspects. Then there is a memory assessment, the so-called Maddox question. So that's like, what's the name of the stadium where we are playing today? What was the score in the last game you played? Things like that. And then there is a very short examination, because it's on the field or immediate. So you do the Glasgow Coma Scale, and you do a cervical spine assessment. Now let's look at the red flags. Again, red flags means there is no way that this player can continue to play. So if he has neck pain or tenderness, if he has double vision, if he has weakness or tingling in arms or legs, for instance, if you have a commotio spinalis, you will have weakness and tingling of arms or legs. If you have a severe or increasing headache, if you have a seizure actually or convulsion, if you lose consciousness, here we have it. So even if it's transient, loss of consciousness is a red flag. If your conscious state is deteriorating, if you vomit, and if you are increasingly restless, agitated, aggressive, that means that you have to stop playing. And from these 2 items maybe of neurovestibular reasons, the double vision, especially the vertical double vision, a skew deviation, can be induced by a utricular damage, for instance, or also a damage within the central pathways in the brainstem. And of course, vomiting can be the result of a peripheral vestibular deficit. Now, let me go to the observable signs. So if you see somebody lying motionless on the playing surface, and that again was in this case definitely the case for at least 4 minutes, if the player shows balance and gait difficulties, is incoordinated, stumbles, has slow movements, etc., that is a sign that you have to immediately act on. If he's disoriented or confused, he doesn't respond appropriately to questions, if he stares around like absent, and if he has a facial injury after the head trauma, these again are signs that demand immediate removal of the player from the field, and maybe he should go, depending on a workup, a short workup, immediately to the hospital. Again, here we have also neurovestibular signs, just 1 actually, that the balance and the gait difficulties could be of neurovestibular origin. Now, in the office or in the locker room off-field, you have a little more time, so it's very clear the player doesn't play again. Maybe you're waiting for going back to your where you're coming from. You're waiting for the bus or for the train or for the plane to go back. So you have a little time, and so you need to know the medical background, of course, of the patient. And there is a symptom evaluation. So there are just a list of 22 symptoms, and you just say yes, no, yes, no, yes, no. And for those 22 symptoms, 4 are, I show you, potentially also caused by neurovestibular deficits. Then there is a cognitive screening, a very short one. You look whether the patient is oriented, whether he can memorize 5 words, and whether he can concentrate by, for instance, if you give him 5 numbers, he should repeat them in the opposite direction. And then there is a neurological screening, which is verbal, how he speaks, whether he speaks normally, spine movement, whether he has double vision when he looks left, right, up, down. You do a little bit of coordination with a finger-nose test. You do tandem gait, and you do a balance examination. And then you do a delayed recall. He has to remember the 5 words that you told him with the immediate memory. And then you decide whether the patient has to stop practicing, whether he can return to play in a graduated way, whether he has to be followed up by specialists, and so forth. And here again, we have some neurovestibular aspects of this assessment, the 22 symptoms, the gaze-dependent double vision, tandem gait, and balance examination are neurovestibular. Now, I don't want to read you the 22 symptoms. There are many of those are very clear: headache, dizziness, sensitivity to noise, drowsiness, and so forth. Of those, probably 4 could be of neurovestibular origin: nausea or vomiting, dizziness, balance problems, don't feel right, whatever that means. Now, the neurological screening, what was the verbal assessment? The question is just whether the patient can read aloud and follow instructions without difficulty. That's the verbal part. Then cervical spine is also easy. It's the passive range of motion of the cervical spine. And then you tell the patient to look side to side and up and down and ask for double vision in these positions. Here you especially are interested in orbital fractures. And then you ask the patient to perform the finger-nose coordination test. And finally, he does the tandem gait, which is a standardized test with a 3-meter line, which is 38 millimeters wide, and he has to go on this line with the eyes open, back and forth. And then there is the so-called MBES, the Modified Balance Error Scoring System testing. The patient has the eye closed and has the hands in the hip and has to stand for 20 seconds. First with double leg, that's easy. Then with single leg on the dominant foot with the eyes closed, and then on tandem stance with the non-dominant foot on the back. And you have 20 seconds, and each error is counted as a point. So that's a standardized balance system test. Here again, we have quite a few neurovestibular items, as you can see. Now, I guided you through the SCAT, and now my criticism from a neurovestibular viewpoint, maybe one could add it in a future edition, with the on-field evaluation where we look for red flags and observable signs. I think spontaneous nystagmus should be included. Maybe they were afraid that many players with congenital nystagmus, I don't know that many, would then always taken from the field because people are not aware of this diagnosis. But spontaneous nystagmus, in my opinion, should be included. In the symptom evaluation, there is a missing differentiation between dizziness and vertigo. I think it's important to ask the patient, is it rather something diffuse or is it really rotating, which then points more to a peripheral deficit. And there is also a missing differentiation between continuous and head movement triggered vertigo. It's just called vertigo. In the neurological screening, I think we should also look for spontaneous and gaze-evoked nystagmus. And the head impulse test should be done. I don't know why they don't do that. I think it's important. And then the BBPV provocation maneuvers are missing. So I think these are really points that should be added for the next edition. Alternating cover test for the vertical skew might also be an important sign. Now, typically, return to play after concussion goes stepwise. So you start here with no activity, and each of these steps takes 24 hours. So you wait 24 hours with no activity, and then you go to the next with light exercise and so forth. And the idea is whenever you develop symptoms in one phase, you go back to the previous phase. So in the optimal case, after a concussion, you're back in the game after 6 days. So that's quite a long time, and that's the optimal situations. Now, if somebody has a vestibular peripheral lesion only, we all know that it's important to activate central compensation as fast as possible. And in these cases, you can have an accelerated return to play protocol. But of course, you have to be sure, or relatively sure, that the dizziness, the vertigo that the patient has is mainly peripheral vestibular. Dizziness is the second most common symptom after concussion. So it comes right after headache, and then also balance problems. So balance problems together with dizziness is actually the most common symptom. So it's important that physicians that treat patients with concussion know about dizziness, know about the most basic signs and symptoms of neurovestibular evaluation. Now, how can we identify dizziness of labyrinthine origin? We already talked about that. Again, I want to stress it. The accident mechanism is very important. And we always have to be aware of if injury can injure the brain, it can also injure the labyrinth. So concussion with a peripheral vestibular damage is very common, those two together. Again, initial signs are imbalance is unspecific, symptoms and complaints are largely unspecific. Bedside tests, there you can identify overt vestibular deficits, and very, very important, there you can find your BBPV, which you can treat immediately. And I'm pretty sure that in 90% of the cases, BBPV in sports people with dizziness after concussion is missed. And laboratory tests are very important because with the laboratory tests you can decide whether there was a contusio labyrinthitis, whether you actually have damage to the labyrinth and not just canalolithiasis. So here we do the testing, vestibular testing battery. I don't want to go into details because you know these tests. I'm going to jump a little bit. Maybe just because you mentioned the rotundum, we use the rotundum quite frequently in the athletes because our experiences, I don't know what your experience is, after head trauma, sometimes the nystagmus is very, very slight. The patient clearly gives a sensation of head positioning vertigo, but the nystagmus is usually very slight, sometimes not visible. And you treat them and the dizziness is gone. So we with the turntable, we can do 360 degrees rotation, make sure that all the crystals come out of the different semicircular canals. And then we do the core vestibular battery, as described by Curtos, the head impulse test, the OVEMS, the CVEMS. We do the dynamic visual acuity, we do now the functional head impulse test, which is going to be mentioned later. We do the subjective visual vertical, we do fundus photography, we do caloric testing, and many times we do also posterography with the equi-test, and the physical therapist does a functional gait assessment. So this is our Occam's rake that we are very determined that this is important in patients after a head injury, because it's not just one reason for all these different symptoms. There are many reasons for the vertigo and dizziness. The problem with the vestibular testing battery is that there are large inter-individual differences. So it would be nice if you had for every athlete the baseline before you had the concussion. So that means that you have to test a team at the beginning of the season and then compare the values if somebody comes back with a concussion later in the season. Now in soccer, concussions are relatively rare. In ice hockey, it's very common, so every team has 5 to 6 concussions per season, so there it's really worthwhile to do the baseline testing. In soccer, it would also be nice, but there's would be a lot of work to do that, and it would be an investment, also financial investment for a team. And that's why baseline testing in athletes, it would be great to do. Now, in conclusion, concussion-associated dizziness may have multiple causes in a single patient, which favors vestibular battery testing, not only clinical but also apparative. Concussion-associated dizziness may often be peripheral vestibular alone or together with central. If it's alone, it's actually a pseudo-concussion, because concussion is defined as a brain problem. Canalotitis after head trauma should be identified and treated immediately. That's why positioning maneuvers should definitely be part of the SCOT 5 or 6 next time. Return to play and return to work after concussion may be accelerated if the dizziness is caused by a peripheral vestibular disorder, in order to make full use of central compensation mechanism. Thank you very much for your attention.
Thank you very much, Professor. Qualcuno ha qualche domanda per il professore? Qualcuno ha capito qualcosa del professore? No, io forse un dubbio ce l'ho. Cioè, se una persona ha avuto una concussione labirintica ed è tornato nella norma, ma a distanza di un anno può avere qualche problema. So, if I have a concussion, yeah, and after 6 days, 6 yeah, steps, I am normally, yeah, no? Yeah. But in the future, yeah, 1 year, 2 years, it's possible to have problems.
Yes. So the literature on that is not conclusive. There is no a literature, at least in soccer, that you could say that it's dangerous. But if you make the parallel to football, American football, you have to be careful if you have repeated concussions, not just 1 or 2, but maybe 7 or 8. And this is sometimes true for players that play in the defense in the center, or those players that use their head many times, and they maybe the ball itself is not enough, but you have to hit another head or the shoulder. That's the problem. But I think a single concussion and you're well after 6 days, you probably shouldn't be worried about that.
Thank you.
Okay.
No. You rest here because I give you 2 tips.
Okay.
One tip is Abruzzo. L'abruzzesità emerge.
Thank you very much.
This is the picture of the Abruzzo.
Thanks a lot.
From the sky.
Oh, okay.
And you can sign the page,
mm-hmm,
which the Capestranos Warriors.
Okay. That's a warrior.
Yeah, the Warriors is the most famous founding in the ancient
Oh, okay. Yeah.
of the
Yeah.
Abruzzo.
Yeah. Okay.
2000
Years ago. Okay. Thank you very much. Yeah.
Okay.
Wonderful. Thanks.
And now the better tradition. Sorry, the better tradition. If you accept this gift, I give you the honorary.
Thanks very much.
So,
I'm very honored. Thanks a lot. Thanks a
the
lot.
Cenacolo.
Thanks a lot.
Thank you.
Thank you very much. Thanks a lot.
And the last, qua non ci facciamo. This is the copy of the ancient book.
Okay.
Of the
You mentioned that.
Yeah. Vertiginem et tussem.
Yeah. Okay. Thanks a lot.
Thank you.
Thank you very much.
To,
Thanks.